Hey everyone, welcome back to a brand new video this week. I'm Dr. Heather Hirsch. Welcome to my channel, Health by Heather Hirsch, where we talk about all things menopause, perimenopause, and midlife. Today's video, I wanted to talk about treating perimenopause, the beast that it is. And so that's the topic we're going to be covering this week. A couple places I always let you know to follow me. On Instagram, I'm at hormone.health.doc, and it's a great place to follow me because I let you guys vote and weigh in on a lot of the topics and video content. Love asking for your advice over there because it's a great, easy forum for that. On Twitter, I post some of my research and more scientific stuff, and that handle is at Heather Hirsch MD. And my website, newly revised, is awesome. That's where I really hold things like my ebook as well as my menopause course, Complete Guide to Menopause, is there. It's an online course you can take whenever you like if you want to really deep dive on all things perimenopause and menopause and really have me walk you through those things. So check those out over there. And last but not least, I have a podcast, Women's Health by Heather Hirsch. I know, totally different title, right? I know, I like to mix it up. Okay, today's video, we're talking about how to treat perimenopause. And in a lot of ways, treating perimenopause is a lot more difficult than treating menopause. Now, if you think about the normal fluctuation of the hormone cycle for women, premenopausally, our estrogen goes anywhere from about 50 to 500 every single month. Up and down it goes. That's how God made us. And that's so at the peak of that, we ovulate. At the bottom of that, if we're not pregnant, we shed our lining, and on it goes. I always tell my patients, perimenopause looks a little bit more like this. Right, until just eventually those ovaries kind of close down shop, and then you really don't make any estrogen anymore. In menopause, estrogen levels typically range between 0 and 20. And the reason that some people may make a smidge, although effectively 0, is from adipose tissue. Our fat cells actually make estrogen, or adrenal glands. Sometimes our adrenals also make some estrogen. Now, in perimenopause, I'm trying to take this wonky system, that's kind of these up and downs and these big crashes and swings, and I'm trying to kind of manipulate it, if you will. Not in a bad way, but really what I'm trying to do is keep things a little bit more even-keeled for you. Now, why do that? Well, the female brain, even though we were made to have hormones go like this, really prefers, it is my belief, a steady state of hormone levels. Again, we kind of weren't made that way, but if you think about your cycle and PMS, which is not a joke, is a real physiologic thing, as those levels are going up for that first week after your period, they kind of steady off for a week or so during ovulation, and some people feel good in their mid-cycle. And then that delta, that change down before your period, that level from here to here, it triggers just, common everyday symptoms that people kind of joke or poke fun at as PMS. But no, really, that change in hormone level causes bloating, acne flares, mood swings, big changes in our physiology. And when that's really severe, I call that PMDD. And that's another thing I could always do a video on, is when PMS becomes PMDD. I do have a podcast episode on that, so I'll link it down below if you want to take a listen, if you think you've suffered with PMDD. But again, that change in hormone level, if you didn't really like that when you were premenopausal, you're probably not going to like it when you're perimenopausal. And PMS or PMDD is certainly a risk factor for a more severe perimenopause course. Now, perimenopause can last anywhere from 1 to 10 years. It's a huge range, but the reason that I say that is because symptoms can be really bad. And if this is something that's going to last you most of your 40s, or, whenever menopause is, but 10 years leading up to that, that's a pretty significant time where if you're not feeling well, let's talk about treating you. So I said that I'm kind of trying to manipulate the system. So how exactly am I trying to do that with, modern medicine? Well, there's a couple ways. The first way you've probably heard of and you've probably even used before, and that is birth control tabs. Now, the reason I want to use birth control pills is because in each little pill, there's estrogen and progesterone. And when you take it on a continuous basis, and I'll come back to that, we're going to keep those levels nice and steady. So when I say continuous, what I like to do for my patients, if possible, is actually have them either take a 91-day birth control pill, something like Seasonique, or just skip the placebo altogether. And I don't mean just not take it. I mean like when that last active pill is done, you check that pack and you start on a new one, so that almost every day you're taking a steady dose of hormones. Why? Well, in the older birth control tabs had 7 days of placebo. If you think about it, you're kind of doing this with your medication, right? Up and then down, and that's kind of mimicking that whole cycle. In fact, there's lots of reasons why there's a placebo week. I've heard lots of various things, none of which have been confirmed, but one, that the Catholic Church wanted it to be like that because it more mimicked a normal cycle, but the scientists who made birth control pills actually wanted to do it on a continuous basis because it just made a lot more sense. When you actually do it continuously, not only do you skip that week where symptoms flare, like I just said, acne, bloating, PMS, weight gain, cravings, but you also reduce your risk for pregnancy. Another reason I tell my patients, not even in perimenopause, but just, premenopausally using it for birth control, to actually skip those placebo pills. Some women find this to be unsuccessful because they have breakthrough bleeding. If you have breakthrough bleeding, then instead of taking 7 days off a month, see if you could go 3 months and try a 91-day pill. Or if you need to take a couple days off every, every 28 days, try taking 2 or 3 days of placebo or no pills and then go instead of a whole 7, so that you just give yourself a steady state of hormones if you can. What that's going to do, that steady state is going to do, is it's going to override your brain system that's kind of making your hormones go really wonky. And so when this works, it works really, really nicely. It works really nicely in particular as well if someone's in early perimenopause versus maybe late perimenopause. Now, it's hard to tell. There's no good lab test to tell if you're early or late. It's really a clinical history, and a lot of it is subjective, or again, as much as I can guess about the female body, she will do what she wants. Typically in early perimenopause, you're having either more periods or they're shortening in cycle. They're like 21 days, they're heavy. Late perimenopause is when you're going 3 months, 4 months, 6 months, and then you get a period. So if you're in late perimenopause and you don't want to use birth control pills because you may have tried these before, you may have had a bad reaction, you simply don't want to do that, what else can you do? Well, this is when I use postmenopausal hormone therapy. Yes, I actually answered this over on my Instagram. You can definitely use postmenopausal hormone therapy if you are in perimenopause. This is a big myth I hear my patients tell me that they have been told, or that's just kind of circulating, that you can only use postmenopausal hormone therapy if you're menopausal. That's really not at all true. So postmenopausal doses can be used in perimenopause, and they're really good in late perimenopause. Now, anecdotally, sometimes I also find they work better than birth control pills, and I don't really know why that is. Maybe it's something with the chemical structure or the way it binds. I don't really know. Birth control pills actually are a higher dose of steady state estrogen than postmenopausal doses. Postmenopausal doses are lower, so a lot of people then wonder, well, wouldn't the higher doses make more sense? Wouldn't that work better? And you would think so, but again, lots of times either people don't want to use birth control pills, or we've tried them and we're going on to something different that caused way too much breakthrough bleeding. Well, we can try postmenopausal doses, which are overall lower doses of estrogen. So there's a couple of ways you can do this. Some of my patients will actually use this more on an as needed basis. How do you do that? Well, I'll use something like the patch. And the patch comes in either a 7-day weekly patch or bi-weekly 3.5-day patch, and I'll have them use that probably either the week before their period or the week when their symptoms really flare. Now this works, I guess, if you can have some sort of normalcy in your cycle, if you're kind of using this as needed or PRN type basis of medication. But this means that they don't need it the whole time. It's just that, you know, as those hormones are fluctuating, that bad week is coming up. You know that you're gonna yell at your coworkers, or, you know, be a crazy with your children, or not be able to function, or maybe even so bloated you just feel like, you know, not getting up, not working out, not motivated. That's the week you slap your patch on. If you have an intact uterus, I'll give my patients a patch with an estrogen and a progesterone in it. Sometimes then this what turns into is my patients find that they might use the patch all the time, particularly if either one, they don't know when their next period's coming, so that system doesn't really work, and they don't know when their bad week is until they're maybe already midway through it, or their periods are just so spaced out that they feel crummy most of the time, not on a particular, you know, cyclic pattern. So then they will just wear the patch on a consistent basis. Yes, they still might have periods, of course, and so I keep having them track their periods, and then we work together and I put on my little menopause detective hat to see when I can figure out when they've gone through menopause. All right, they could also use postmenopausal hormone therapy in a tab. So some of my patients will take oral estradiol, or a combination of oral estrogen and progesterone. And again, this works really nicely if it's, you know, more likely that you're in later perimenopause. Again, some people, the best I can do, they're gonna have perimenopause for 6 months or a year. So that can really, again, the lines can be really blurry. But, you know, postmenopausal hormone therapy on a constant basis, a daily basis in like a tab, a combined estrogen progesterone also works really well. Sometimes I use postmenopausal estrogen alone if someone is really in early perimenopause, or maybe even has PMDD or PMDD severe perimenopause, without using a progesterone if they're having pretty regular periods, because I know that their body is making enough progesterone, and I see how they do on that, and then you know, over time I'll add a progesterone, because you always want to protect someone's intact uterus. That's the main reason to take progesterone. I did a whole video on why to take progesterone. I'll link it here if you want to check that one out, just for more information on when, why, and how to use progesterone. So yes, I really wanted to answer the question that you can use both birth control pills or postmenopausal hormone therapy to help treat perimenopause. Now, one of the biggest things, taking a huge step back, that you can really do is journal and track, because you will start to see if any of these things happen on a cyclic basis, and if they are cyclic, then that really helps you know the days that are coming up that are going to be more severe, and the days that you think you're going to be fine and flourish, and you should really plan around that. That can make things really a lot more functional for you and really happy overall. So just a tidbit here on how to treat perimenopause. Remember, if you want to see me in my clinic, I work in Boston, Massachusetts. I can do telemedicine in New Hampshire and Rhode Island. However, to do telemedicine outside of those states, you do need to see me in person for your first visit, and then the rest can be via telemedicine. So hopefully time to travel will get better, and that could be an option for you. I'd love to see if y'all want a video on resources. Again, if you want to find a doctor closer to you, a great resource for that is the North American Menopause Society website. That stands for NAMS, and the website is menopause.org, and go under search a provider, and you can click it in by your zip code and see all the NAMS certified practitioners. Now, not all created equal. However, that's going to be your best place to start if you found that your internist or your OBGYN or your family doctor didn't give you the answers that you were hoping for. So that's a good place for you to start. Again, if you want a deeper dive, check out my course, The Complete Guide to Menopause, at heatherhirschmd.com. That's heatherhirschmd.com/course, and you can check it out there. I think the first lesson is free, so definitely go ahead and check it out. Let me know in the comments below, did you know you could treat perimenopause this way? Have you been misdiagnosed? Have you been correctly diagnosed? What did you find during your perimenopause course? Thanks guys so much for watching this video. As always, please like and subscribe. That is so helpful for the algorithm to recommend this channel to other women searching all across the world for menopause questions to their searching for answers to their menopause questions. So that helps so much if you subscribe, like, and or comment on this video. So thanks again. I love to see this community really grow and flourish, and I'll see you next week's video. Bye.